In terms of the labor room care, the recommendations include obviously deferring the clamping the umbilical cord. So delayed umbilical cord clamping, we can also name it as late umbilical cord clamping or the physiologic umbilical cord clamping. So the cord clamping should be delayed unless there is a real contraindication. So that is physiological. You can review my videos on delayed cord clamping for more detail, but it is physiologic. It is the blood that should be coming back to the baby, and in a premature baby where hemodynamic disturbances are much more likely, the lack of this 20 to 30% blood volume will impact the baby's outcome. And that's why if you miss out the 20-30 ml of milk, the blood that the baby is supposed to get back, these babies can have a higher risk of IVH. The risk of jaundice is very minimal. You don't need to be worried. And even though there is a mild polycythemia, because the blood volume increases at the same time, it's not going to affect the risk of hyperviscosity in these babies. So please reiterate that you should do delayed cord clamping. Again, teach your obstetric team that these babies, when they are premature, don't cry, they are not vigorous at delivery. Encourage them to feel the cord pulsation, and if the cord pulse rate is more than 100, they can safely wait 30 seconds to 1 minute. Again, the labor room temperature should be clearly adjusted to 24 to 25 degrees as recommended, and OT temperature as well. So you need to negotiate, educate your obstetric team the importance of this, and don't leave a choice. It's almost like what the baby should be getting. You shouldn't deprive the baby of this. Another important point is the stem cells that this fetal blood is rich in. All the immunoglobulin that was transferred to the mother, the dose that will come is like 20 to 30 ml per kilo more of the blood volume, which has this high, very rich in stem cells as well as immunoglobulin, which will play a big role in helping these babies cope with the stressful newborn period. So please don't miss out on delayed cord clamping. Cord milking can be considered in babies more than 28 weeks, but in the babies who are younger than that, there is a risk of possibly increased risk of IVH, as shown by Anup Kataria and his team. So we have to be cautious about cord milking in the smallest babies. For the resuscitation part, TP's device should be preferred rather than bag and mask. So obviously the benefits are clear, that you adjust the pressure better, you can deliver PEEP better, the inflation time is regulated better. There is no role for prolonged inflation at delivery. Sustained inflation is not recommended. Spontaneously breathing babies should be stabilized using CPAP, so don't immediately intubate the baby. If they are apneic or bradycardic, start giving ventilation breaths, and the expert consensus is to start with CPAP pressure of 6 centimeter water with a PIP of 20 to 25 centimeter. So obviously if the baby continues to need IPPV, then you intubate these babies. Oxygen for resuscitation should be controlled using a blender. So this is not an option anymore. Any unit taking care of newborns should have blenders in the labor room and in the NICU as well. We should use an initial FiO2 of 0.3 for babies less than 28 weeks gestation, and 0.21 to 0.3 for those 28 to 31 weeks. So room air is adequate for more than 32 weeks. So it's important that we start with some oxygen for the smaller premature babies, and there are still studies on Torpedo 2 and so on, which are looking at ranges in between. So the Torpedo 1 had looked at 100% versus room air, versus the Torpedo 2 is giving different cutoffs. So we can go 30 to 60% maybe to start with. And because the oxygen is important to maintain the airway open as well in the small babies, and it has been shown that a saturation of 80% or more to be achieved within 5 minutes is important for a better prognosis. We can consider titrating, starting with 30 to 40% and titrate down. So the smaller the baby, the higher the need for this slightly increased FiO2 at delivery. We should hopefully get more clear information on this soon. Intubation should be reserved for babies not responding to PPV via face mask or nasal prongs. There are some resources looking at laryngeal mask airway for the initial inflation. Again, for the bigger babies, most people are suggesting we can use LMA above 1.5 kilos, and experience is increasing. Once we get the 0 size, probably this will increase as well. So the seal efficacy is much better. If you are using a face mask, remember that the trigeminofacial reflex can cause reflex bradycardia. So be careful about how you hold the mask, not to press too hard, and to relax and make the seal effective in an appropriate way. And there are also studies which are looking at use of high flow at the time of delivery. That's not established practice that can be considered in your unit if you are able to set it up. Two people doing the IPPV is also beneficial. One person stabilizing and holding the mask with a good seal, and the other one doing the bag. If you have facility, go for these options. And plastic bag or occlusive wrapping under the radiant warmer, and the humidified gas should be used during stabilization of babies less than 32 weeks gestation to reduce the risk of hypothermia. Hyperthermia should be avoided as well. So some people have looked at servo control temperature regulation. It doesn't change the outcome, but anything that improves the awareness, the focus on the labor room temperature, the focus on using the warmer properly, using the plastic bag. Sometimes when we use a thermal mattress, babies have been shown to become hyperthermic, so that should be avoided. So we have to be watching for both hypo and hyperthermia prevention.